All right, good morning, everybody. It is now week 8. This is Dr. Garais, Med120 4DAX, and this is term 3. And what's due today? Of course, everything from the musculoskeletal, which is, and please inform me if your medical language laboratory is giving you some trouble. But according to the publisher and our chief librarian, she tested it last Thursday, and she says it's fine. Me, it's glitchy. Like sometimes it works for me, sometimes it doesn't. So if it doesn't totally work for you, either log out and try to log back in. But if that doesn't work for you, I have paper exercises that I've scanned that I could send to you that we could utilize instead of these exercises. And of course, make sure to keep on doing your quizzes and making up your quizzes for the discussion forum. And the same format will be repeated for this week as well. So of course, by closing of business today, all of that is due. And what's for this week? It's reproductive, and that's module 8. So let's jump to our book, and hopefully it's working for me today. If not, we have to do something else. See, why does it do that? It blocks me, and I don't know why. Resources, instructor. See, if I can access this. Why can't I access my book? You know what I'm saying? All right. Okay. So another thing we could do. Oh, wait, whoa. It just did it right there. Stupid me. There you go. Analytics cookie, opt-out cookies, save, good. All right. Okay, now it works. So reproductive system, and of course there's male and female. And the female, of course, is the specialty that deals with the female is OBGYN, which is short for Obstetrics and Gynecology. IC pertaining to obstetrics, that's for your female patient that is either pregnant or thinking about getting pregnant. So everything that's related to fertility, and closely related is gynecology. Logi, study of anything regarding female. So they also deal with breast tissue and also to some potential anatomy and physiology and pathology issues that may lead to issues with fertility and getting pregnant. Now, the male counterpart for like if my patient's female and has genitourinary tract issues, they go see a gynecologist. But if it's a male, they go see a urologist. But in the case of, you know, in a fertility clinic, it's kind of like annoying if I have to go see two specialists. Like, let's say my wife and I are having trouble conceiving a child. Back in the old days, I would have to go to a urologist, and my wife would now have to go to an obstetrician. But nowadays in a fertility clinic, there's a subspecialty called uro-obstetrics or urogynecology, which that particular physician can see both the potential father and potential mother in a fertility clinic. So again, OB-GYN, someone who studies obstetrics and gynecology knows both. But nowadays, because of insurance costs and things like that, there are a lot of obstetricians that opt out. They only do gynecology because the insurance for delivering a baby is very, very high. And of course, urology, what are they experts at? They're, of course, not only experts at male genitourinary concerns, they're also experts at the urinary tract. Now, the urinary tract includes your ureters, your urinary bladder, and your urethra. It's kind of overlapping the Department of Nephrology, but the Department of Nephrology solely deals with anything kidney problems. Okay, so a urologist, if the issue, like let's say for example, it's a chronic urinary tract infection, if that gets out of hand, it could elevate all the way up to your kidneys, and then we'd have to call in a nephrologist. Okay, so remember, urology, male genital urinary problems, or male or female that has issues with either ureter, urinary bladder, or the urethra. So let's go to a female reproductive system. It's a little bit more important than male. Well, let me be honest, it's a lot more important than male. In medical school, obstetrics alone is a 2-year course. I remember my urology course in medical school when I was in training was, I think, 6 weeks. We'd like to focus on female repro because of its importance regarding childcare and childbirth. So this is a nice picture here. If when you're studying your anatomy and physiology, you have your ovaries here. I mean ovaries right here. There's 2 of them. You also have your fallopian tubes. There's 2 of them. There's one. There's another. And of course, this muscle here in the middle, which is the uterus, and then connects into the vaginal canal. And again, if any issues with this and or breast tissue, any of these structures, the specialist to go see is your gynecologist. Unless you have issues with, what happened in my picture? You have issues with, that's weird. It was there 1 minute ago. How'd that happen? What if I did? No, I don't want to do that. Let's just go do this. It's moments like this where I miss just a regular book where I can just turn the page and not be at the mercy of the internet. Well, just to keep, while this thing's loading. The other goes, if you could see, I use the term genital urinary, because it's not only the genitals or the sexual organs such as the ovaries and the testes. It's also, if you see here, there's urinary. So you have right here, see, it did it again. What is up? Ugh. Monday is not being kind to us. Well, like I said, genital urinary, if you look at the word genital urinary, let me see if I do this, if I refresh. See if anything happens. Nope, it's the internet. Okay. This is another thing we could do so we don't waste our time. I think I have notes in my old, unless if it's an internet issue in my home. But no, I got full signal. Let's look at my old 120, see if we have any notes. Week 8 video lecture. Nope. No, no dice. All right. We're back to here again. And I promise not to hit that same button again, because when I tried to magnify the picture, that's when things went awry. Well, back to what I was stating. Genitourinary, it's not only your genitals or things that that have to deal with your secondary sexual characteristics. And secondary sexual characteristics are the thing that makes you either a man or a woman. So their urine and your kidneys and urology, nephrology, even though we study all of these things separately, they're related. And you can see here that muscular tube is your vagina. It's the tube. It's not the orifice. We typically talk about the vagina as the vaginal os or the vaginal orifice. The vagina is actually the vaginal canal, and that's what it's termed as. And then you could see here the urinary bladder is here, and then you have your urethra, which is the tube that leads out into the outside world. And of course the anus, which leads into the rectum. Now you could see from the proximity of the anus to your urinary os or urinary orifice and your vaginal canal, you could see a very, very great potential for urinary tract infections here. And remember, UTI doesn't necessarily mean STD. STD is sexually transmitted disease. UTI is urinary tract infection. And again, there's some overlap, but they're typically discussed as two entirely different things. Now, you could also see that if there was baby in here, in the uterus, this will get very big, right? And you can see how it will also press on the urinary bladder, which may lead to some urinary incontinence for mommy, okay? And also the same thing, these tubes are all very close to each other. So when mommy has a lot of children, all of these muscles here, you see there's muscles here, this is your pelvic floor muscles, they get loose, and then your vagina and your rectum could have prolapse, meaning to say is this tube can go out and this tube can go out. And of course, what we mentioned, some urinary incontinence. So if you know your anatomy, it's kind of knowing your pathology, it's kind of easy to see some things. So let's start looking at some of these word elements. Amnio. Now, the amnion is a sac of fluid that covers baby. And we already know from week 2, centesis means a surgical puncture, so we can obtain a sample. Now, amniocentesis is good if the mommy has history of any birth defects in the family, especially neural tube defects. And also, we also look at some maternal and fetal blood incompatibility. But mostly, it's for looking to see if there's any evidence of any genetic abnormalities. Not necessarily to promote abortion, but to, mentally prepare mommy for what is to come. Cervicitis. Itis, inflammation or infection of the cervix. Now, if you recall the picture of the uterus, do you see here how it kind of narrows here and here? That's your uterus. And I've used the term os for opening. So you have an internal os and an external os, and then you also have your vaginal wall here. That's the area that you try to get a sample of when you're doing a pap smear, also known as a Papa-Nicolau smear, which is a screening test for cervical cancer. Sometimes when you use that screening test, we'll use a colposcope, especially if I want to do a biopsy, colposcopy, scopy. When you look at that Y, you think process of, and what do we do with the scope? Process of visual examination of the vaginal canal and, of course, the cervix. And we use that in the pap smear, formerly known as your Papa-Nicolau smear. And they're looking for cervical dysplasia, which is the beginnings of cervical cancer. If we look at the term dysplasia, let's break down that word. Dys, plays, ia. Ia is state or condition. Dys is abnormal. And plas is growth. Now, you don't get cancer just out of nowhere. There has to be some sort of damage or some sort of abnormal growth first, and then it's going to cause inflammation, and then from inflammation, you're going to get abnormal cells. From abnormal cells, if they continue, it can then become cancerous. So just like most things, if you can get the things or get the pathologies early, we could stop it at this inflammation abnormal cell level before it gets to full-blown cancer. And especially if the patient has a history of human papillomavirus, specifically subsets 16 and 18, it screams, you are going to get cervical cancer, so you're going to have to do something about it. And cervicitis, inflammation in the beginning, is the beginning of it all, if we see it. Vagina or the vaginal canal, vaginocele, that's the herniation I was talking about. If you have a loosening of the pelvic wall due to multiple children. Galactorrhea, rhea, abnormal discharge or flow, excessive flow, galacto, of milk. Remember, milk is a good thing, but too much of a good thing is bad. Too little of a good thing is bad. And we have hormones in our body, or mostly in female bodies, that are called lactogens. They are things that promote the production and secretion of milk. And of course, lacto means milk. And if you know lactose, ose is the suffix that means sugar. So lactose is the milk sugar. Now we're always promoting mommy to breastfeed, because the one thing that we can't make in a factory or a lab is the antibodies that mommy can give baby. Because when baby's born, all intents and purposes, it's immunocompromised and it has no real immune system other than their skin and mucosal lining. So getting anything extra from mommy, especially in the way of antibodies, is always a good thing. And it's always a good thing. Keep baby at home. I find it very silly, especially nowadays, when people bring newborns to the mall. The mall is the dirtiest place in the world. Why would you bring a newborn there? But again, these people aren't stupid. It's just that they don't have training and they don't know that in your typical air, just walking around, there's hundreds of things that could do damage on you, but your immune system blocks it. But a baby doesn't have much of an immune system, so it's best to wait a couple of months. I recall my mother telling me, because since I was a very premature child, she used to not let people touch me my first 6 months to a year, because of course, especially nowadays, now everyone now knows that germs and viruses and everything can easily be transmitted via touch, and now we realize that hand washing and aseptic technique is very, very important. We already talked about gynecologist. We already talked about obstetrician, which will probably be somewhere down on the list. Now, let's look at this word, hysterectomy. Hyster means womb. Ectomy means removal of. So when we do a hysterectomy, we remove the entire uterus out. And once you remove the uterus out, our female patient can no longer have children. Now, we do that because maybe it's polyps, maybe it's cancer, but let's also look at this word hyster. If you guys know the word hysterical, the word hysterical means what? Crazy, ridiculously funny. Be careful when we use that word, because you now know it has a very misogynistic connotation. It means that what? That once a month, because somebody has a uterus, they're going to act a little crazy. So not a nice word to call a woman hysterical. Actually, my mother had a case years ago where she successfully won against another physician who said those words and similar words to her as a physician. And as a woman, she didn't appreciate it, but she did the right thing, reported it, and got the physician's sanction, right? Because if you don't say anything, the behavior will tend to continue. Uterovaginal. It's not only the uterus that you're interested in, it's the vagina or the vaginal wall. And the pap smear is a uterovaginal test. It not only tests the opening of the cervix, it also tests to see if there's abnormal cells in the vaginal wall. Breast, mammo. Another good screening test is a mammogram, right? Now, I've mentioned the word screening test and definitive test before. Remember, a screening test is only is for an asymptomatic patient. If you're positive on your mammogram or if you're positive on your pap smear, it doesn't mean that you have cancer. It means that there's something there we should investigate further. So for example, pap smear or mammogram comes back positive, what we now must do? We now must take a biopsy, right? Actual piece of the tissue, bio, life. We bring it to pathology, and they tell us if it's cancerous or not, or even precancerous or not. Now, you've heard of a mammectomy, like if you do have cancer and it's really, really deep and thorough, we have to remove the entire breast. And in order to do that, we also have to perform a mastopexy because there are muscles and other things associated with the breast tissue, and we have to keep those in place. And a mastopexy, which is fixation, that's fixation of your rest of the breast tissue that we didn't remove, so that you'll be able to still use your arms, because your pectoral muscles underneath your breast tissue, if those get cut permanently or they get damaged permanently, you will not be able to raise your arms. Your pectoral muscles are part of that. Meno or menstruation, menses means monthly. So a patient with menorrhagia, they have a bursting forth. Just like the word hemorrhage, it is a ridiculous amount of blood. Classic menorrhagia. I had a patient came in, her only chief complaint was, "Oh, doc, I'm feeling tired, and I'm feeling a little peaked." She had a little pallor, she was a little pale. Then I took her history. I asked for her LMP, her last menstrual period. Oh, it was just last week. Okay. And she goes, well, my menstrual cycle tends to be a little long. And then I was thinking, well, a couple more days long. Apparently her menstrual cycle was almost 2 weeks. Not only that, when I asked her average per day, how many pads per day? I'm expecting, a single digit number. When she said 11, or when a patient has to look up at the sky to calculate how many pads she used, and she was in her early 20s, and she's been like that since she was 15, and it was very disconcerting that no one ever really looked at that. And that's a classic menorrhagia, a bursting forth of her menstrual cycle. It was too long and too extreme, to the point that it was causing her pallor, or she was starting to become pale, and she had iron poor anemia. Uterus, meter is another uterus. So if you have endometritis, you have inflammation or infection of your inside of your uterus or womb. Now, you could utilize your knowledge of medical terminology in anatomy and physiology, because you're going to have structures, even though you haven't had may had not have anatomy and physiology yet. You don't have to memorize the layers of the uterus. Means structure of, peri means surrounding, and the middle layer is the muscular layer. So that's the structure of, myo, the muscular layer of the uterus, and of course endo is the structure of, endo, within or inner layer of the uterus. So the menstrual cycle comes from the shedding of the endometrium. The cramping that you get comes from not you if you're a male student, but our female counterparts, myometrium, muscular, and perimetrium is the tough covering that surrounds the entire uterus. So don't have to look at a picture. Just knowing your medical terminology, you can easily identify structures and layers within you know, just really not within, without, and through. So endometritis, my patient has the inflammation or infection where? On the inside. If they had perimetritis, they have inflammation or infection on the outside or surrounding layer. Myometritis, they have it within the middle layer or the muscular layer. Nat means birth, right? For example, nationality, where were you born? You have prenatal, perinatal, and postnatal care. Perinatal is very, very important, so so are the other forms of care, but prenatal care is the weeks leading up to childbirth. Perinatal care is everything that we do up until baby comes out, and then the second baby out, you have postnatal care. But all three stages are important, and understanding them is and knowing the timing is knowing the prefix here: pre, peri, and post. O4, this is ovaries. So you could have an oophoroma, a lump or a bump or a tumor within my ovaries. And then if I see that upon ultrasound, I have to perform a biopsy, right? Ultrasound is a nice screening method. I see a lump or bump, and then I have to do a biopsy, and then I got to send that to pathology, and they tell me if it's cancer or not. Ovary, ovariorexis, sometimes there's a rupture of the ovaries. And again, we have to go in there and do ovarioplasty and go repair it. Now, the perineum, I already showed you that. That's the area in between the anus and the vaginal orifice. And sometimes, well, not sometimes, after first baby, I have to cut that area so that baby can fit through the vaginal orifice. And then we perform a perineoplasty, right, to suture and repair that area, right? And that's not fun for mommy, and but it's very important so that all the area can heal nicely. Salpingectomy is, again, ectomy. I'm removing my fallopian tubes. Now that we saw the fallopian tubes, the ovaries, and the uterus and how to remove them, there's going to be a point where, especially if there's a large threat to multi-organ damage, pathology, or cancer, we will perform something called a TABSO, TAHBSO, and that stands for Total Abdominal Hysterectomy with bilateral oophorectomy. Now, that looks like a 25-cent word, but we know better, so let's break everything down. First of all, I have to enter my patient via the abdomen or the lower abdomen. And what's the first thing I'm doing here? First thing I'm doing here is removal of one uterus, because my patient only has one uterus. Now, bilateral means bi, two, later, sides. So pertaining to both sides or two sides. And I'm removing two fallopian tubes. And I'm also removing two, and you see the O for ovaries. Now, my patient's going to need a lot of HRT, which is hormone replacement therapy, because what do you think the ovaries were supplying mommy with? Or not mommy, but our female patient. I always say mommy regarding obstetrics. So you could see that a TABSO, total abdominal hysterectomy with bilateral salpingo-oophorectomy, say that 5 times fast, is a removal of one uterus, two fallopian tubes, and two ovaries. And then, of course, you have a post-surgical prescription for hormone replacement therapy until the end of days, unless they want to forgo that, because your patient's going to, when we take all of this stuff out, your patient will experience post-menopausal um, um, symptoms. So post-menopausal. So al pertaining to meno, your menstrual cycle, pause. Usually happens during female around mid-40s onward. And that's when the menstrual cycle ceases. And when your menstrual cycle begins, when you're younger, and that's called menarche. And I mentioned LMP is last menstrual period. Okay, so that's a tabaso. That's what HRT is, and LMP is also a nice a nice abbreviation to know, because we're always asking that. It's in obstetrics. One of the things that we're always doing in obstetrics is always getting a urinalysis, and we're always asking about LMP, last menstrual period. Now, remember that perineorrhaphy? I barely can say that. The suturing or repair of the perineum. Well, the thing that I cut is called an episiotomy. That's the incision or the cut that I have to make in order to widen the vaginal opening for delivery of the fetus. And we typically do that for your primogravid mommy, or the first time, prime meaning the first time mommy had pregnancy slash delivery. We mentioned menarche, menses. It's the beginning. Now, let's now talk about the telephone code, para and gravida. Gravida means pregnancy. Para means the actual delivery, and typically the delivery between 38 and 40 weeks age of gestation. And age of gestation is from the time you got pregnant to the time of delivery, which is typically 40 to 42 weeks. So let's look at G and P, gravida and parida, or gravity. It's the and parity, which gravity meaning pregnancy, and parity meaning delivery of a viable infant. So let's do this. Okay, so that's called the telephone code. Well, at least the first part of the telephone code. And it's like, maybe you'll see something like this, G1, P0. Maybe you saw that on the chart or something like that. So gravity, we already talked about, was pregnant. Or how many, or the number of times my patient's been pregnant. And parity is number delivery, and that's the number of times. So if we're looking at an example is G1, P0. And typically this one will be like written like this, like a sub, it'll be written like that, or in slashes. Now, what does that mean? Gravity, she's only been pregnant once. Now, did she ever deliver the term or deliver any baby? Never delivered. Now, when it's the first time for anything, prime means number one. So my patient could be primogravid. And if it's the first time they've ever delivered, they could be primiparous. Now, if they were pregnant a whole bunch of times, then my patient is multigravid. If they delivered a whole bunch of times, my patient is multiparous. And if they've never been pregnant, my patient is nulligravid. And if they delivered a whole, and they never delivered, my patient is nulliparous. So let's review. Primogravid, that means it'll be G1, right? Multigravid, it'll be G2 whenever. Most I've ever delivered from a woman, she was G12. She had 12 kids, and I delivered her 13th. She was such a pro, she delivered herself almost. G0, nulligravid. Never been pregnant. If someone's primiparous, their code would be P1. If they were multiparous, their code will be P2 onward. And if they're nulliparous, the code will be P0. Now, there's more to the telephone code. You'll learn it in obstetrics when you guys get to further training. But this is, these words are, and remember, if you can't remember which one, gravity versus parity, memorize one like your life depended on it. And then the second one is simply the second one or the other one. To me, I always think gravity pregnant, right? And then parity is just the other one. So that's gravida and para, and that's the telephone code. Salpingo or salpinx, hematosalpinx, that's blood in the fallopian tubes, right? Not good. Most likely is from either ectopic pregnancy and or torsion of the uterus or torsion of the ovaries. Because if any of those things start like torquing around and twisting around, it'll cause a bleed. Oh, let's look at that word ectopic pregnancy. Get rid of that. This ectopic. So it means pertaining to, out of, ec is like X, place. So the only place that baby should be implanting is the upper anterior portion of your uterus. Anywhere else is an ectopic pregnancy. Anywhere else is a non-viable pregnancy. That pregnancy will not go to term. And even worse, that pregnancy will cause problems like bleeding. So we have to remove it. Tosha, dystocia, is bad or painful. Now, childbirth, of course, is painful, but mommy will know if something's wrong. I'm from the school of no matter how much training I have, I'm not a woman, and I have no idea what that pain is, and I don't want to know that level of pain. But when mommy says something's wrong, something's wrong. And that's when you have to pay attention and listen. And almost every time that mommy, even the primogravid mothers, when they told me, doc, something's wrong, I sit up and I pay attention and I investigate fully. Because dystocia is not normal delivery pain. It's something worse, okay? It's something different. It's something, and your patient knows that there's something wrong. So, but let's look at this word TOC, T-O-C, and maybe some of you ladies who had, there's a message. Okay. If some of you ladies had a, you know, that little, looks like, I don't know, it looks like this little plastic headphone on a Velcro piece of elastic belt, and they put it on your tummy when you were delivering. That is a tocodynamometer. Dynamometer. Now, meter means measuring, right? Because toco is labor, and dyna means movement, right? So that, because the tocodynamometer actually measures two things. Of course, movement of the baby, and FHR, which is fetal heart rate. Now, if there's any decelerations, So typically the fetal heart rate is going to be fast. It's going to be like 180, 185, even up to like 200, right? And there's going to be always movement, especially around the time where mommy's having contractions of her uterus, because it's going to get closer and closer to when baby has to go down. But if we see on our tocodynamometer any decelerations, that is an indication for an emergency C-section, right? It'll be an EC section. That means we have to get baby out now. And the cesarean section is when we do the surgery to get baby out per abdomen versus a vaginal birth. So dystocia, right? That goes, the tocodynamometer will pick up on that. Retroversion, the tipping back of an organ, specifically the uterus. Retro means back, and version means, in obstetrics, it's called lie, like how something lying or laying down. If you see here, do you see how naturally you even see the curve right here, and there's a curve here, and the uterus, look, it's actually facilitating like a little ramp, facilitating baby to exit mommy in a nice clear fashion. But what happens if this uterus is tipped the other way? And then now, not the uterus, yes, the uterus is tipped this way, and now the cervix is now pointing towards the vaginal wall. Baby will have failure to descend. So then we do what? We got to go in here, and we got to go do C-section. Got to go through in here, open up this, and then whoop, get baby out. Very easy to say, very hard to do. I've only did a dozen of those C-sections in my life, and each one was an adventure. And that's retroversion. Okay. If you have uterine retroversion, we have to either get that corrected through manual manipulations, or we have to just go in and do a C-section. And you can see here again the area for you have your internal os, external os, vaginal canal, and that's the area where you do the pap smear. And you can see here it's a cervix or a neck. This is the body of the uterus. This is the fundus, or the top part. You know, when someone's pregnant and you want to feel their tummy, this is the top part. That's the part we measure. You have your ovaries here, broad ligament. And these are called fimbriae, or fingers of your fallopian tube, right? And then the best implantation is here in the upper anterior portion of your uterus. Anywhere else, sometimes it implants here, here, inside here, all these crazy places, right? But those places are not viable and actually can cause damage to mommy. And here's a subtotal hysterectomy, right? We just get a little bit of the hysterectomy. Total hysterectomy, I'm going to take out the entire thing. And the tabaso, I'm going to take out this whole thing. 2 ovaries, 2 fallopian tubes, and the uterus as well. And with that, you must have, anytime you remove the ovaries, you must have hormone replacement therapy, or your patient has to be counseled to know and understand that they will have postmenopausal symptoms. And you've heard of the classic symptoms: irritability, mood swings, a lot of hormonal changes, also hot flashes, right? Because of the hormones. Now, this is an example of a DNC, or dilatation and curettage. You could see here we have a vaginal speculum to keep the vaginal canal open. And then we stick this thing that looks like a probe, but this is called a uterine sound. It is a way to measure to do pelvimetry and to measure the distance from the uterus to the os and also the vaginal canal. We also use it if I'm having a colposcope, if I have a lesion here, because each one of these little measurements is out to a centimeter. So this is called a uterine sound. Now, a little bit larger, heavier tube with a little hook on it, and that's a cervical dilator. When we do a dilatation and curettage, I need to dilate the cervix here with this dilator. So I twist this tube and it kind of jars the cervix open just enough so I can stick this curette. And a curette is this serrated spoon. It's not always serrated, but it's very, very sharp. And we do that to scrape the endometrial lining. And you can even see here, you have your perimetrium surrounding the uterus. You have your thick muscular layer, and that's your myometrium. And then you have here this layer inside, and that's your endometrium. And that's the layer that builds up in order to support baby. But if you don't have a baby, it gets sloughed off every month, and that is the source of your menstrual cycle. But if we have to take a sample, or if we have to remove anything here like cancer or polyps, we use D&C, a dilatation, which was this thing, and then a curettage, which is a curette that will scrape all those things. And yes, it's painful, and we need anesthesia on that. Okay. Urinary bladder, what are they talking about here? Oh, vesico-vaginal fistula. A fistula is just a connection. Now you can see here, there's some damage, and now it's connecting the urinary bladder to the vaginal canal. And it'll be, you can even have a fistula here between your rectum and your vaginal canal. And fistula just means an abnormal connection. And again, it happens because if you have baby, no baby, baby, no baby, some of these structures here, especially here in the pelvic floor, which is all these muscular tissues here, it gets loosened up to the point where it tears. But we got ways to fix that, and that's in obstetrics and gynecology. And obstetrics is wonderful because it's a partial surgical, partial medical service. Here's breast tissue, and you can see here, there's a lot of fat and there's a lot of glands. And if I have ductal CA or ductal carcinoma, some of these glands will get invaded with cancer. So I have to remove them all. And another thing that I'm also removing are all of these lymph nodes. That's why when you do your, ladies, if you do your monthly breast self-examination, do not forget your axillary lymph nodes. Don't forget to feel in your armpit here for any lumps or bumps, okay? Because if there's cancer here that you can't feel, your lymph nodes, you'll have lymphadenopathies. They'll become positive here in your axillary area or your armpit area. And remember to do it sitting down and lying down because the breast tissue acts a different way regarding gravity. And more exercises. Now let's look at the male. Male has, as you can see, has similar things. You have urinary bladder with the urethra and the urethra going out into the outside world. Now, instead of our sexual organs being all the way up in the abdominal cavity, if you have male chromosome XY, it will then descend, and then your testes, which produce sperm, get through the epididymis, right? And then get through this tube called the Vas Deferens. So when we perform a vasectomy, this is the thing that we cut. Ectomy, meaning removal of a section of your vas deferens. You here have your prostate gland, and it's also with your ejaculatory ducts. And you have all these different glands that you don't have in your female patient because the sperm needs to be prepared before it leaves the urethra. And you'll learn that all in lovely anatomy and physiology. Or maybe not, because it's one of the last chapters, and I usually eat up a lot of time in my anatomy and physiology class on the female menstrual cycle, because that's a big topic in NCLEX. So let's look at some male words. So androgen, gen, formation of, andro, male. So if I give testosterone or androsterone, which are steroids, if I give that to a female, what will they now look like? They will now start to have secondary sexual characteristics of a male. Their voice will get deeper. You'll see a jutting of the jaw. The jawline will start to get chiseled. There'll be something, there'll be nuchal prominence. The back of their head is going to get more prominent. And of course, the most important thing, especially the athletes, is they'll have increased muscle mass. They'll put on weight much different. So that's why when I look at, it's super obvious in sports, especially female sports, which ones are doing performance enhancing drugs or PEDs. Glans penis, which is the head of the penis, right? Balan is the root word. So balanitis, inflammation or infection of the glans penis. Doesn't always have to be an STD though. Gonads, of course, that's your sexual organs. For female, it's your ovaries. For male, it's the testes. Females make ova or eggs, and the testes, of course, make sperm. So gonadotropins are hormones or chemicals that will increase these things on both sides. Testes, orcho. So orchitis is inflammation or infection of the male testes, most probably secondary to some history of mumps. Cryptorchism, remember I mentioned that your testes have to descend from your abdominal cavity? Well, especially with premature babies, it doesn't go all the way down. So we have to surgically bring them down. And then when we surgically bring them down, we have to perform an orchiopexy and fixate them to the scrotum or the scrotal sac so that they don't go back up. Orchid Ectomy, if there's cancer, or if there's massive amounts of damage caused by a saddle injury. Usually motorcycles cause that. So your scrotum and all that, it can blow up to the size of a small, like almost to like a beach ball. It's scary. And then we got to remove all the blood and things like that. So it gets damaged, so we have to remove it. And testalgia, of course, pain in the testes. It's easy. Prostate gland, prostatitis, right? It's not prostatitis, it's prostatitis. Inflammation or infection of your prostate gland, right? Spermatozoa or spermatocyte. Now, spermatocyte is the mature sperm cell. Spermatozoa is like the precursor or the stem cell prior to the spermatocyte. And of course, spermicide is anything that kills sperm. Most common one is called nonoxynol 9. It's in most of your hospital grade hand sanitizers, which begs the question, well, why did we put nonoxynol 9 in typical hand sanitizers? Who's leaving sperm all over, all the counters in the hospital? Never understood that. But, overkill, especially with chemicals, is always a good thing. Aspermia is my patient has a state or condition of no sperm. My patient could also have oligospermia or very low sperm count, right? And in both, there's two things that we're looking at regarding sperm is motility, how well do the little guys swim, and number. Because remember, only one can make it to the ovum or to the egg. So all intents and purposes, everyone on this planet who is born is a survival swimmer. Varicocele, dilated veins. Vas deferens, we already talked about that. That's the tube that leads from the testes to your prostate. And if I cut that and seal it off, that's called a vasectomy. But still, no one understands. Life always finds a way. There's something like a 0.08% chance that you could still get pregnant even with the vasectomy. And that's nuts because we actually cut both sides, either suture or cauterize or burn the ends. But it's amazing. Sperm will find a way to get to where it needs to go. So it does happen. And again, these pictures are great if you're studying anatomy and physiology. Oh, you could see how, knowing your anatomy and physiology, you see the prostate gland, you see how it gets all inflamed. This is benign prostatic hypertrophy. So this is not cancer. Hyper means excessive, trophy means growth. This is not cancer. This is just an extreme inflammation or extreme prostatitis. But you could see now how the patient's going to have a hard time urinating because this is the urinary bladder and the urine will get stopped up here. So your classic sign and symptom is the patient's complaining of dysuria, either some pain or they'll say that, oh, when I pee, the urine just dribbles out. This is TURP, transurethral resection of the prostate. So let's say I have to cut little pieces out of the prostate so that this tube can be nice and free. We utilize this procedure called TURP, T-U-R-P, or transurethral resection of the prostate. We put in a resectoscope right through the urethra, and then we go in here and just like endoscopy, we could see it, and then there's these little teeth here you could see here that can retract, and then we can get biopsies, and we can also do suturing and surgery here by opening up this inflammation in here. Okay. Why is it scrolling so slow? A vasectomy, of course, you see here, we found the vas deferens and then we cut it. We not only ligate it or cut it, right? I mean, we not only cut it, we ligate it, we tie it down, or we burn the ends using cautery, and still people get pregnant. Amazing. Okay, look these over. We went through most of them. OCP, oral contraceptive pill. The telephone code we went, HRT, hormone replacement therapy, IVF, in vitro fertilization. That's when we introduce um, uh, um, daddy's sperm and mommy's egg outside of the mommy. That was affectionately called in the 70s test tube babies, but it's not really so. It's not really as dramatic as that is. LMP, OB, TVH, total vaginal hysterectomy, ED, erectile dysfunction. Now, ED also means emergency department, so, or the Department of Emergency Medicine. So be careful using this. But ED, a lot of guys know what that is. PSA, prostatic specific antigen. It's the test for prostatitis and BPH, which is benign prostatic hyperplasia, also known as benign prostatic hypertrophy. And remember, BPH is not cancer. Now, DRE, which is digital rectal examination. Now, why in heaven's name would I want to stick a finger in my patient's rectum? Well, let's see why. If you look at this picture, if my patient has prostatitis or BPH or even cancer, don't you think it's going to form a bump here on the rectal wall? So if I stick the gloved K-wide hand, we use KY as a lubricant, of course, right? I start feeling around the walls here, and because even before I do the ultrasound, I can now see if your prostate and or your urinary bladder are enlarged or abnormal. Okay, I can even feel here, this is called your cul-de-sac, if there's fluid or blood, and that's what a DRE, or digital rectal examination. And we do the same thing for female because it's a way that I could see the inner structures. And of course, I confirm with, and of course, tubal or ectopic pregnancy. Tubal pregnancy is in the fallopian tubes, but all these areas here, these are non-viable areas. Baby will not live. And in the interim, baby will cause a lot of damage. Okay. And this is colposcopy. Okay. We want to view the vaginal canal and cervical area. It's very useful for pap smear, and it's very useful for if I need to visualize the cervix, because the way we do biopsies, I paint the cervix with iodine, and any abnormal patches, that's where we get the biopsy from. Here is also a laparoscopy. Lapar, meaning the abdomen. We either fill the abdomen with gas or normal saline, and then we could do surgeries this way. And it's much, much better healing process. There's only 3 puncture holes that we put in our patient. One for to scope, one for to do the procedure, and also to introduce the gas or the water, and another hole to as drainage. And that's much, much better than me cutting up your entire abdomen. It's the difference of being in recovery, days versus months. And here's a nice picture, DRE. And this is the reason why I do a digital rectal examination. You could see I could feel something wrong with either the cul-de-sac, the bladder, or the prostate. Oh, this is the episiotomy. I do not do it there. Jeez, who did this? You do it here at 6 o'clock or 4 o'clock here. Don't do it there. There, you're going to get a tear, and it's going to tear all the way to the level of the anus, and that's not good. And that's called your episiotomy. Mastectomy, lumpectomy, we already talked about that. And all these other, they're neat things here. What is this? Brachytherapy, and not too common. Now let's look at some pharmacology, logi, study of some drugs. Antifungal, of course, is a drug that's against anti-fungus. Remember your HRT, you have to give estrogens. Contraceptives, contra means against. Ception means pregnancy. Oxytocics. Now, oxytocics, right? Oxytocin is the hormone that signals your uterus to contract, and that's where you get the contractions. That's where the pain comes in. So some of you, maybe one of you ladies during childbirth had induced labor, where we give our patient what is called a pit drip. We give them the synthetic drug called Pitocin, which is an oxytocic, and the oxytocic gives strength and frequency to the uterus, and that's very painful to mommy, but it helps pushes baby out. And ladies, if you ever wonder why every month you have cramps, it's because it is your body's way of practicing before the main show of actual labor. Because remember, if you don't use something, you lose something. So there has to be maintained muscle tone in the uterus, hence the monthly cramping of your uterus. Spermicide, we already talked about. Erectile agents, that's for, now erectile agents are actually mild hypotensive drugs, right? It has a localized hypotensive effect because when you think about the little blue pill or Viagra, it was initially an anti-hypertension drug. It was made to drop your blood pressure, but it had this wonderful side effect of producing erections. And you'll learn about why exactly in anatomy and physiology. And gonadotropins, those are hormones and or drugs that will promote growth of what? Gonads. Either increase your sperm count or increase your the number of eggs you release per month. You're only supposed to really release one. But if you ever see those shows where, you know, it's those families who have like 8 kids, 9 kids, because they were on fertility meds. Now, you may think that multiple pregnancies are cool and cute for TV, but for medical personnel, it's dangerous. If any of you known any twins or triplets, you know that one is the dominant one who's never sick, and then the other two or the other one is usually sick or smaller or has issues. And also, if you look at the psychology of twin studies and triplets and even more, they the the dominant personality will be the eldest one, and then the other two personalities will be not as strong. I have triplets in my family, and it's so true. All 3 of them were, you know, they're all great kids. I love them dearly, but it was super obvious which one's the dominant one, and which one were the followers, or which one was the weaker personality. But they're all great kids. But you can next, if you can research twinning studies, or if you have any twins in your family, take a good look at their personalities and their health histories. One has a ton of problems, the other one doesn't have any. Because remember, mommy's only built, female anatomy is only built for one child. So if there's more than one of them is going to be the dominant one, and the other one's going to suffer. That's why I am not a big fan of these fertility meds, because there's a risk. Now, of course, the discussion 8, or the discussion for this week, of course, do the same thing. Pick one of these cases, have your 5 questions. You can either have that emergency room case above, or this operative report here below. This guy looks like Ashton Kutcher for some reason, right? And some of you, I see how you're utilizing some of these questions here. Good show, to make a multiple choice examination. Now make it a little bit more challenging. Some of you make it like really easy. Remember, make it a little bit more challenging, so that because one of these days, if ever we go back to campus, I take all of your quizzes, mix and match them, and I give them to I give them to your colleagues. That's actually how I used to do it when this was on the ground class in the before 4. I used to have the day students make up exams, and the night students make up exams, and then I used to give the exams to the opposite team, and we used to have like contests and see who would do better. Overall, it was pretty even, but you'll start noticing it's very interesting that if you can preempt your professor, understanding their quizzes and understanding their assignments will be much easier in the future. So, does anyone have any questions, comments, and recipes? And for that one person who wanted to ask me a question, you could stay on and let me just take the attendance, like so. All right, and that concludes this lecture for today. Anyone have any